I didn't meet your daughter, I don't think. Did I meet you in the
No,
hospital?
no.
Or I did. So, we obviously, when you went in the hospital, are you recording?
Yeah, I
That's
just
okay.
did not your face.
That's okay. I don't care. It's fine. When you went into the hospital, you really did not have any knowledge that you had
No.
any heart problems. And when you left the hospital, I, of course, diagnosed you, or we'd already diagnosed you with severe heart problems. And so we can kind of step back and go through this sequence of events. They brought me into the case. I think I saw you on the 3rd, 12/3.
Okay.
And one of the blood tests, which is the marker for heart muscle damage called the troponin, was quite elevated. In fact, it was elevated at over 3,000, 300,700. Normally it should be like less than 50.
Right.
So massively elevated. Of course, that in conjunction with chest pain you were having and an echo showing that your heart was weakened led me to do a cardiac cath, which we did on December the 5th.
Mm-hmm.
To refresh your memory,
Mm-hmm.
we all have 3 arteries in the heart. Let's look at this small heart model here. They're called the left anterior descending, the circumflex, and the right coronary. The left anterior descending is 100% occluded. The right coronary is 100% occluded. The circumflex, which is really the only one that's keeping your heart going, has two 90% blockages in it.
Right.
So basically, the only artery that's keeping your heart going has two 90% blockages in it. So this is a very, very dangerous situation. In addition, your ejection fraction, which is how well the heart's squeezing, in a normal person that should be around 55 to 60%. Yours is only about 20%, or maybe even less than that.
Okay.
So we're in a pretty bad situation here. Now, you fortunately did respond well to the medicines that we gave you, and you're still taking them properly.
Mm-hmm.
But in order for me to formulate a strategy of how we're going to move going forward, I had recommended that you have what's called a viability study.
Okay.
Which is called a cardiac PET scan.
Okay.
Now, my understanding is that you were supposed to get that appointment for that before you left the hospital. Did that happen?
No,
Okay. I had asked case management to do that for you, but they didn't do that. Is that correct?
That's correct.
Okay. All right. So we'll take care of that.
Where do I go to get that? Is
Medical
it here in the
center.
hospital?
No.
Okay.
We don't have the only reason. I mean, I would have done it in the hospital if we had the technology, but there's only 3 or 4 PET scanners in Houston
Oh, wow.
that are capable of doing this kind of imaging. There's a lot of PET scanners.
Right.
There's a PET scanner that is in the back of a semi truck that comes here, and we do scans here for patients who have cancer. Most people are familiar with PET because of cancer imaging, right? So that's the way it's most commonly used. But for cardiology, there's a very specific use of it in looking for heart muscle viability. PET stands for positive emission tomography, different than CAT scan. CAT scan is a CT scan, which is basically just an X-ray. A PET scan is a metabolic scan, so it detects how much the heart is alive and how much it's functioning and how much it's metabolizing glucose. And if the heart muscle is completely dead, it'll show up as sort of a dead zone on the PET scan. If the heart is normal, it'll show up as normal metabolism. But if it's kind of in a state of hibernation, meaning that it's still alive but yet underperfused and hibernating, then it has a specific appearance that gives us a clue that if we were to restore blood flow to the heart, i.e. with stents or with bypass surgery, then that heart will wake up. 20% ejection fraction will improve to 55-60%.
Oh, okay.
So that's the whole point of doing the PET scan, is to try to give us some idea or a predictive value of how well you would or would not do if we were to expose you to, say, bypass surgery or something like that.
Okay.
So that is a very important test. We need to get it done.
Right.
I had hoped, if you will, that case management would help get that organized or scheduled before you leave, but that's okay. We'll get it set up for you.
Okay.
But it's a test that I have to order and then has to get done at the med center.
Right.
So you are a dialysis patient.
Yes.
You have dialysis which days of the week?
Monday, Wednesday, Friday at about 2 p.m. to 6 p.m.
Who's your nephrologist again?
Dr. Pandy, he's in this office, this
I
building.
know.
Mm-hmm. Mr. Clickety Clack.
You can hear him walking down.
Yeah, we all make a joke about it. Here comes Dr. Pandy in his fancy schmancy shoes.
Italian loafers or something?
Something in his clothes.
He does like to dress well. That's
Yeah,
for
he
sure.
does.
I been wearing scrubs every day for 20 years.
Not Dr. Pandy.
Sit up for me.
Sure.
Take a deep breath. Out. Deep breath. Out. Deep breath. Out. Did I cast you from the groin, right? We went in from the right groin.
Yeah, we were trying. Yeah.
Any bruising,
No,
bleeding?
no,
Nothing?
I didn't even know it was there until there was like a little Band-Aid gauze, and I was like,
Good.
okay. Surprise.
Do you have a copy of this diagram?
I do. I have
Okay.
two.
You are on a drug called midodrine.
Yes.
You only take that as needed, right, for dialysis?
Yes, but I also got a prescription where it says to take it every 12 hours.
So how are you taking it?
Every 12 hours.
Okay.
Yeah, because yesterday I forgot to take it, and I was at dialysis, and they wouldn't start because it was so low.
Okay.
And I was like, oh, I got it with me.
And you have not started taking aspirin yet?
No.
Why not?
CVS didn't send it, and I didn't realize they didn't send it. So, yeah.
Can you give me a box of those aspirin things from up here?
Thank you.
Yeah, we got a bunch of that stuff. It's like occupying space back there. So
Oh, hey, I'll take it. Hello.
We need to give it away. All right, so, and you're just taking a half of that metoprolol tablet every 12 hours?
Yes.
Okay, it looks like you need a refill on that. It has no refills on it.
Okay. I think I have it with, no, I left it at
So
home.
are all these, I mean, there's a bunch, is the rosuvastatin, which is your cholesterol medicine, the Farxiga, and the metoprolol, those are new medicines for
Yes.
you, right?
Yeah.
So I'll need to refill those for you.
Thanks.
Do you understand what the Farxiga is? Are you a diabetic?
No, yes.
But do you understand what the Farxiga is
No.
for? Okay. So Farxiga is historically a diabetes medication.
Oh.
However, yes.
Daisy. Hi.
Hi.
However, in some of the studies with that drug, when we were looking at it in diabetic patients, we showed that patients who had heart failure tended to do better than those that did not take the Farxiga. So we scratched our heads and said, there's something interesting here.
Yeah.
So we started designing studies looking at Farxiga as a heart failure medication.
Oh, wow.
And we even enrolled in this most recent study, more than half the patients in the study were not even diabetics at all. They were heart failure patients. And so Farxiga has been proven to be beneficial in heart failure, whether your heart's weak or whether it's strong. If you have heart failure, it works, whether you're a diabetic or not. And if you're not a diabetic, it doesn't cause your blood sugar to drop. Like you might
Okay.
think.
Yeah.
I think about giving a diabetes medicine to somebody who doesn't have diabetes, it's going to
Right.
become hypoglycemic.
Yeah.
It doesn't happen. But so that's why you're using it for heart failure, not for diabetes, but for heart failure.
Okay.
The beauty of the medicine is it doesn't affect your blood pressure. All the heart failure meds that we use, Entresto, lisinopril, valsartan, olmesartan, all those drugs that we use all the time for heart failure lower your blood pressure. And since your blood pressure is so low to begin with, even so low that you have to take midodrine so that you can successfully have dialysis, it would be a disaster to put you on, something that's going to lower your blood pressure even more. I'd
Right.
probably kill you. So that's why you're using the Farxiga. So it doesn't affect the blood pressure, but it does help your heart.
Okay.
So there we go.
So what's the one that starts with an R that's new?
rosuvastatin.
What
That's
does that do?
cholesterol medication.
Okay, that's
That's a
cholesterol.
cholesterol medication.
Okay. Wow, that's a big box, Doc. I thought maybe it was going to be a bottle.
No, it's several bottles. That's
Wow.
yours.
Thank
I'll
you
save
so
a little
much.
bit of money.
That's very kind of you.
Okay, so here's what I'm going to do,
Look
Virginia. I'm going to facilitate with my office the cardiac PET scan.
Okay.
Today is December the 22nd, so I doubt seriously it's going to be done before the end of the year.
Right.
But once that's available, then I'll be able to tell you one of two things. if the PET scan shows that your heart is just, unfortunately, at its end stage, there's really nothing else that we can do other than medications, okay? And which is kind of what we're on. If the PET does show that you've got some viability, meaning that the heart still has the potential to recover, then I'm going to present your case to a surgeon, okay? Because in that case, you might benefit from bypass surgery. 1, 2, 3 bypasses. The only issue there is a surgeon's going to take a look at you. Here's a dialysis patient. She's got one leg, she's got an EF of 20%. What are your risks of even surviving an open heart surgery? Maybe not good enough to justify the risk of the surgery. So then they'll probably turn around back to me and say, well, can you fix this lady with stents? So those 90% blockages, clearly I can stent those. Even these 100% blockages probably can be stented. I have to, do some manipulation with a wire to get a wire across that. If so, then I can put a stent in there. It might be 3 different procedures. I might be able to open 2 out of 3. I might be able to open 3 out of 3. I don't know. But there's still a lot of uncertainty, as you can see here, and it's all really going to depend on what the PET scan shows.
Okay.
What to do is the next step.
Right. I understand.
How's your breathing?
Fine. I don't have any problems
Good.
breathing.
What about chest pain?
Haven't had any.
Okay, good. You're lucky.
I'm just moving along.
Well, these blockages didn't happen suddenly. This built up over time.
Yeah.
Probably over years.
I don't understand how they never found it. They were doing EKGs all the time. I don't know why they didn't find it.
Nobody bothered to do a heart cath on you, I guess.
Mm-hmm.
PET scan for myocardial viability. I'm going to put on there for a follow-up visit with me in 3 months.
Okay.
If I see something on the PET scan that needs action before then, of course, I'll call you and bring you back.
All right.
Okay.
I know. You're busy.
Thank you for coming in.
No, thank you for all the information.
What other questions? Did I answer all your questions for you?
Yeah. I mean, you're pretty. Yeah. I mean, I can't. Can you think of anything to ask?
What do
I
I
can't
need?
either.
Is there anything I need to refill besides those that I highlighted? Because I think those are the only.
No, I
ones
saw my PCP yesterday, and he did the diarrhea medicine for me. I asked him though if he could up the dosage, but I don't know if he said he could or not. I think he said I was at the.
That's a problem for you?
Yes.
Diarrhea.
Yeah. See, I thought I had irritable bowel syndrome, and I keep telling everybody, and they're like, no. And then when I was in the hospital, they did 4 tests. They all came back negative. The IG doctor said he was stumped. So when I was talking to my doctor yesterday, he said, well, did they do a biopsy? And I said, no, they didn't do one. And he said, well, they should have done one.
Was there a GI doctor seeing you in the hospital?
Yeah, Dr. Krill. Wait, no, Krill.
Krill.
Like the fish. Yeah, Dr. Krill.
My doctor was Dr. Kill.
Yeah, Dr. Krill. Sorry. I see him on the 11th of January.
Okay, good. Yes, I was looking at the discharge summary.
But I don't really feel very happy with him if he didn't even do a biopsy. I don't know how much trust I have in him. I guess I'm going to have to be the one that says, hey.
I will say that, did they do a scope on you? Did they look in there with a scope?
Nope. All they did was take samples.
But I will tell you that, and I don't remember if they asked me or not, but if they probably were scared of your heart to do it, to be honest with you, about sedating you, and putting the scope up, because doing a colonoscopy is kind of dangerous, and if you got a heart like yours, they probably were using that as a rationale as to why they didn't think it was appropriate to do a scope on you. To biopsy, you have to do a scope, right? So to put a scope in requires sedation.
Right.
That's a stress on the heart. And so with your heart, they probably were scared.
Yeah, but I've never had any problems with sedation. Didn't you sedate me for the...
I did.
Yeah.
Yeah, I did. I'm just trying to...
I know. I appreciate it.
Very nice to see you. Merry Christmas, okay?
Thank you. Merry Christmas to you, too.
You got your aspirins. Okay,
Yeah,
good.
that's my Christmas gift. I'm going to wrap it.